So next up will be Mark Moon talking about surgical triggers in aortic valve disease, and then I think we'll be back on sequence.
I think we fixed the mouse
What do we do to move it? Do you know?
If you just press the mouse or the button, it's going to work.
Okay.
Just press the mouse and it should.
Get it going up.
They do.
There we go. Well, as we all know, aortic sclerosis is a common finding in the elderly. 25% of people over 65 years of age and 48% of people over 84 years of age are going to have some sort of disease of the aortic valve. It may not be clinically significant at that point, but it's certainly the instigating process. The progression in aortic stenosis occurs in 16%, and as our population gets older, that's going to amount to a large amount of people. Symptoms are obviously classic: angina, syncope, heart failure, decreased exercise tolerance, dyspnea on exertion, and those are all the classic indications that the disease has progressed to something that we're going to see in our offices to evaluate. We've all seen this slide. The survival is terrible once symptoms present, and that's obviously our first indication for surgical intervention. So our initial triage is to put the patients into either the symptomatic aortic stenosis group or the asymptomatic group. The symptomatic patients really have no other option. That's surgery. The asymptomatic patients can have a normal ejection fraction. They generally, though, once the stenosis gets significant, display hypertrophy, diastolic dysfunction. And once ejection fraction falls below 50% or pulmonary hypertension starts to develop, then an AVR is indicated, even if they're clinically regarded as asymptomatic. With a normal ejection fraction, and I'm sure Blaise is going to talk about this a little bit as well, you can consider exercise testing to unmask latent symptoms or hemodynamic changes. Transthoracic echo is used to identify the etiology of the AS and also quantify the hemodynamic severity. The severity of the AS nowadays is considered significant if the aortic Vmax is greater than 4 meters per second. You can see in the graph the Vmax being less than 3 is generally associated with the long-term survival without aortic valve replacement, whereas it progresses to over 4, that's when the event-free survival falls dramatically. What is really the percent of patients who are asymptomatic? Once we do exercise testing, a couple different studies have shown anywhere between a third of patients and 2/3 of patients can be demonstrated to develop symptoms with exercise testing. Looking at the impact of the peak aortic gradient, we find that the factors that predict AVR are an abnormal systolic blood pressure response with a decrease in the pressure, systolic pressure of 20 millimeters of mercury or thereabouts, any ST depression, and symptoms that occur during your exercise testing. The impact of the peak aortic gradient doesn't really affect your results with your exercise testing, but when you do have an impact of exercise testing on the development of symptoms, the event-free survival falls dramatically again. So with a negative stress test, 15% of patients only need an aortic valve replacement within 24 months. But if you have a positive stress test, well over 80% will require an AVR. So that's the first thing to do, is to do an exercise stress test in these asymptomatic patients. One other issue is the impact of frailty. The assessment tools that we've used over the years are the eyeball test, of course, and that's been pretty effective. But people have tried to quantify that more with new measures to measure frailty. We know that comorbidities will lead to frailty, but also frailty will lead to disability. It's a continuum. Frailty can be defined now as 3 of the following 5: weight loss, 10 pounds without intention, self-reported exhaustion, grip strength that's weak, walking speed, or decreased physical activity. The 5-meter gait speed, taking more than 6 seconds to walk 5 meters, has been found to be very predictive of frailty. 208 patients that underwent AVR at the Royal Brompton, and they compared their results based on the 6-minute walk test. That's if you can walk over 300 meters. That occurred in 49% of their patients, less than 300 meters in 51%, so about 50-50, obviously. The proportion of patients experience an event, death, myocardial infarction, or stroke with aortic valve replacement was substantially higher in the patients who couldn't walk 300 feet. Almost 15% incidence compared to 3 or 4% in the patients who could walk over 300 feet. So the frailty not only predicts how long a patient will survive, but also how they'll do with the initial intervention. Looking at impact of 6-minute walk test stratified by the preoperative Euro score, there is an important difference though. In the low to intermediate risk patients, there wasn't a substantial difference. But in the high risk patients who had a predicted Euro score greater than 6, the death, MI, and stroke was over 20% risk with surgical intervention compared to less than 4. Back in the late 80s and early 90s, there was the impression that balloon aortic valvuloplasty was going to put us out of business and could take care of these patients long term. That didn't pan out. BAV only was associated with pretty poor 3-year survival, less than 25% compared to patients who underwent BAV followed by an AVR. Crevier's group recently reviewed their experience with BAV in the higher risk patients. They had procedural success in 81%, mean gradient falling from 44 down to 21. But 36% of these patients only underwent aortic valve replacement. The goal with their BAV in this series of patients was to see how the patient did, to see if they could get them tuned up for an AVR. 64% though remained inoperable. And the medical therapy group was poor. The SAVR group, surgical AVR, did a little bit better in the long run than the TAVR. So what we do is look at patients with poor ejection fractions or who are frail, consider doing a BAV to see if we can improve their functional status to get them to a point where they might be able to undergo a surgical intervention. This group looked at BAV in 16 patients with an LVEF less than 20% and found that half of these would increase their EF over 20. The mortality, however, was quite high in this group, 31% at 30 days, so this isn't a procedure that's done without risk. Currently, we use the BAV as a bridge to decision. We assess the reversibility of frailty, symptom relief with LV outflow tract obstruction relief, and to determine whether these patients and their aortic stenosis is responsible for their lung disease, hepatorenal disease, and other comorbidities that may be preventing them from undergoing surgery at the initial outset. For patients whose rehab potential is in question, there are 3 different options. One, three things we always do. We institute aggressive congestive heart failure medical therapy and see how they do. Secondly, we can consider doing a BAV and then reevaluate their functional status 4 to 6 weeks afterwards to see if it's improved. If their functional status has improved, then we do an AVR. If no improvement, we can continue with the medical therapy and lean them towards the hospice. Looking at the patients with low gradient, low EF, AS, the survival is very dependent on the function of the heart. Patients, though, however, who have a low gradient, low EF, can do quite well after AVR and can have an 80% survival at 4 years. When you compare this to their non-surgical option, the survival is 10%. So if we can get these patients through surgery, it's something we should consider. We can do a dobutamine stress echo to look for contractile reserve. If they've got findings that are consistent with contractile reserve, then we go ahead and offer them a surgical intervention. Now, a high-risk AVR in these patients does carry a higher mortality rate if they do not have contractile reserve. So in our center, if a patient doesn't have contractile reserve, we will treat them aggressively with medical therapy, consider a BAV, and follow them up in 8 to 12 weeks to see if it's improved. A couple last things, looking at bicuspid disease, Borgen and David's group from Toronto looked at what to do with the aorta in a patient with a bicuspid disease. If the aorta was greater than 4.5 centimeters, then they generally recommended ascending aortic replacement. But during the ascending aortic replacement, if the patient has a bicuspid valve that's not calcified, it's functioning normally, I would generally lean towards leaving that valve in place as opposed to replacing it. Now, the patient who's in their 60s, who might have calcification buildup in the raphe, that might be or 70s, that's a patient you may lean towards replacement if you think it's starting to stenose. But oftentimes, if they look totally normal, we just leave them in place. And the final topic is patients undergoing major non-cardiac surgery. If they're asymptomatic and they're undergoing a moderate risk surgery, then they don't need to undergo an aortic valve replacement preoperatively. There's no data that shows that that's necessary. They can undergo intensive, and should, intraoperative and postoperative hemodynamic monitoring to look for any fluid changes and balance that out. The real question comes in to the patient with a high risk, undergoing a high-risk non-cardiac surgery, for example, liver transplant. Those patients are at high risk for undergoing an AVR before a liver transplant, and I have not leaned towards that approach. Rather, we would consider doing a BAV 8 to 12 hours. There is a window before a liver transplant where you can perform that if in fact you feel their stenosis is relevant. So in summary, the triggers for aortic valve replacement include anybody with symptomatic AS, asymptomatic patients with diminished left ventricular ejection fraction, asymptomatic patients with positive functional testing, low gradient, low EF AS patients if there's contractile reserve, borderline patients with questionably reversible non-cardiac comorbidities who undergo a successful bridge to decision, and during ascending aortic replacement if there's a high likelihood of rapid progression. Thanks, David. Thanks, Greg.
Mark, I know you've got to run to the council. Can I ask you one question, and that's about staging BAV to TAVR? So you do a BAV, and the patient gets better. Now you've made their aortic gradient better. Are we obligated still to wait to then do TAVR for them to redevelop moderate or severe aortic stenosis, or how are you handling that?
Yeah, I think in our bridge to decision algorithm, it's the patient who comes in that we look at who would have flunked the eyeball test originally in years past. And that's a patient we offer a BAV, and then we bring them back always in 4 to 6 weeks. We know the BAV is not going to last 4 to 6 months, or it can, but in the rare patient. So we see the patient back in 4 to 6 weeks. If they say, I feel better, or they're now able to walk the 5-meter test in a substantial, appropriate time, then we'll just line them up and do the TAVR right then.
You know, that's a situation where there might be a big difference between how you're required to behave in a clinical trial context and how you would behave in the real world once you're out of the trial.
Right, exactly.